I'm super excited to have you here today, and thank you so much for giving your time to reach people. So we're going to start off with the general questions that I have, and then later on we're going to get into lifestyle modifications. We're going to talk about pharmaceuticals, non-pharmaceuticals as well. So 50% of people with migraine, according to one source, have their first attack before the age of 12. Are you able to break that down for us in terms of early childhood versus adolescence, and what stage people generally start having migraine?
Well, migraine can happen at any age, and you'll be surprised that even younger kids, 1, 2, 3 years old, can have it. And of course, the percentage is much, much lower, 1 to 3%. We did have a patient as young as 18 months that was diagnosed with migraine. It's harder to diagnose at this age. Then the percentage is going to increase between 8 and 11 to about 10%. In general, it's 10%. It will be between 4 and 11%. But the increase in the rate of migraine really goes very high during adolescence, and it can reach up to 25% specifically in girls.
Right.
If you read the science, is about 80% of kids will have a headache before the age of 15. Not specifically migraine, but a headache in general.
Wow, that's incredible. There's just so many people that are struggling, right, very early on in life, and yet there's so little awareness about it. One of the stats that's often quoted for adults with migraine is that 75% of the people with migraine are women and 25% are men. Is that different during adolescence?
The difference is actually depending on the age of the patient. So most of the patients at a very young age are boys, and this during adolescence totally flips, and you will have 1 out of 3 is a boy, so the rest are girls. So there is some difference between boys and girls through puberty.
All right, interesting. And what is the chance of a child having migraine if they have a parent who has migraine? How much of a difference does that actually make?
About 85% of our patients, we will have a family history of migraine. The other 15%, we cannot get it, or they don't know, or they never ask specifically, or the parents will say it's a sinus, it's not a migraine. But about 85%, there is surely one first-degree parents with migraine headaches.
Wow, that's incredible. That's, again, so many children that are going to be struggling. And it's important for parents to know that, even before they have children, right? So they can recognize the signs of that. We know that obviously there's no cure for migraine yet, even though we see lots of advertisements that say that there is. But what is the chance of adolescents outgrowing frequent attacks or going into remission as they get older?
Well, that's a question everybody will ask. Is it going to be cured with the treatment we're going to give them? There is no cure, but that's not being pessimistic, because it can be controlled depending how early you treat it. I would say what we tell the parents, if we catch it early, we have more control in adulthood on it. The brain is still young, and we can prevent it from becoming chronic. Now, the boys, about 50% can outgrow them in their 20s. So they're lucky. But for girls, I do tell them that it's a lifelong disease. They don't outgrow it until menopause, which is really far for an adolescent, but that it can be well controlled. And usually controlled for us is less than 1 headache a week that goes away really quick with their treatment.
Wow. That's incredible. Thank you. Thank you for letting us know that. One of the things that we have heard from a lot of young adults, especially because we're looking at young adults this year also, is the impact of migraine on their social life, on the feeling of being isolated and disconnected. Maybe you could share a little bit about that impact on adolescents at that time of life.
Yeah, it can be very disabling. And I'm going to let Dr. Slater take over, because she sees them in her clinic, and she sees them more often sometimes than myself.
Yes. So I do think, migraines can have, a pretty big impact on the social functioning of children and adolescents with migraine. And generally, I have kids and adolescents come in and say, sometimes their friends or classmates don't really understand. Like, they say, oh, everybody has headaches. So it's for them it's different when they're like, yeah, no, but my headaches are really making it so that I can't, come out of the house, or I don't want to come and hang out. But I think generally, what we focus on is to try to help adolescents know that we don't actually want them to be isolated, that actually can make their headaches worse, can make their mood worse. And so, what we try to target is, okay, what can we do to try to help you spend more time with your friends? Because that can be an effective treatment. So generally that happens a whole lot just because people are saying, yeah, I need to have the lights off. I want to be by myself. And so we kind of try to present the same message. Dr. Kabbouche and we kind of say, hey, listen, we want you to treat it immediately, maybe take a few minutes, but we don't want you to be isolated because that can have a negative impact both on your headaches and on your functioning.
Right. Absolutely. That makes total sense. Let's just maybe you could add to that a little bit about stigma. We know that stigma affects different people at different stages of their life. What is the unique way that having migraine impacts adolescents in terms of stigma?
Oh, sure. No, I do think, like I was saying before, I think, sometimes others who don't, have chronic headaches or chronic migraines can downplay the impacts of headaches on like school, family, and social functioning. And so I think sometimes adolescents with migraine feel that people are not really listening to them or kind of understanding how difficult dealing with this particular chronic condition can be. And so sometimes treatment with me does kind of work on, okay, how to give them that confidence again to know that migraines don't have to control their life, that, sometimes it involves providing some education. So sometimes we provide letters to different people like teachers or principals, nurses to say, hey, listen, this is what, having a migraine headache means. This is what it looks like in a teenager. This is how they might present to you. This is how we would like for you to respond. We don't want you to single them out. We want you to allow them to have their treatment. We want you to encourage them to continue to function.
And to add to that, we do have a lot of patients who come in and they're frustrated because the teachers don't believe them. They think they want to be out of the classroom. And once they hear that we believe them, just that point is already a step forward to getting better.
Right. Absolutely. That makes total sense. That's really helpful. In addition to the stigma, and it's the impact of migraine on isolation and relationships. Let's talk about the relationships within the family. How does that impact the family when there is, a child or young adult or adolescent, experiencing severe migraine?
Yeah, no, I think it can have a really big impact on family relationships. And when I'm meeting with families in my own clinic, when I'm meeting with patients, I always tell patients, like, we want to involve your parents so that we can kind of teach them ways that they can be supportive of you. Because I think it's important for parents and siblings to understand what's going on. Okay, what do I need to do? How can I be supportive? And so, as I said, we don't want them to isolate themselves. But I feel like that happens a whole lot where families say, oh, we weren't able to go out to do this thing because my child had this migraine. We had to cut things short. And so sometimes that actually is the focus of what we talk about is how do we kind of get the patient or the adolescent back involved in family activities, because that can be an important part of treatment as well.
And the parents sometimes feel very frustrated that my kid is in pain and I cannot do anything to them. And that creates a lot of stress to the parents and the kids. Yeah.
Right. Absolutely. That's hard. How much do you think parents should talk to their adolescent about migraine? How much should they understand? How much voice do you think they should have in terms of treatment options?
Well, when we see a patient, usually the parents are there, we do focus on talking to the patients. And we explain to the parents so they don't feel they're left out. It's that this is their headaches. We want them to really describe it themselves. We want them to be involved in the treatment, but they do have a voice. I tell the parents, please stop us. If you have anything, stop us and let us know. So the history, I usually want it from the kid. And then the treatment, I still discuss it with the child just to see their opinion, what's their input, because they know if they're not going to take the medicine, nobody's going to make them take that medicine. So they have to get their input. But the final decision is on the parents, and their involvement is really important too.
Yeah, yeah, absolutely. That makes sense. It's important to include them. Obviously, not adults, so it can get really complicated.
Yeah.
Talking about school, what are some of the accommodations that parents can request for their child? And a lot of parents who have children in school don't realize that migraine can be seen as a disability, and that you can formally request accommodations. What are some of the typical accommodations that are requested?
Yeah, so we have several that we will suggest to families, and when I talk to them, I'll say that usually it involves on basic things like, okay, they should be allowed to take their medication at school and have their sports drink, to be able to hydrate at school, use the bathroom, have snacks at school. And sometimes when their functioning is significantly impacted at school, sometimes we will suggest a formal plan, like a 504 plan. And so in those ways, we do ask for, sometimes my patients need accommodations like extra time to do tests, extra time on assignments, breaks during the school day, when they need to. Usually it's those sort of things. What we do try to stay away from is to provide blanket excuses for school absences, just because our general idea within our entire center, whoever they talk to will probably tell them the same thing. It's just that we want you to function. And actually not functioning and you being at home and missing more school creates this sort of negative loop where you miss school. I always tell the family, and they believe, they know that it's true. So nobody's ever gotten mad at me at saying it. Like, if you miss school, when you come back, you'll be stressed out about all the work you have to make up. Stress actually can be a trigger for headaches, and you miss more days. So then school becomes this negative place to be because you always feel like you're behind. And so we try to kind of change around that conversation from, hey, can you excuse me for these things, about how can we make school a more tolerable place for you to be versus not being there at all.
Right. Absolutely. Yeah, that's so tough. Like for two of my children started having migraine at the age of 9, and both of them ended up having a 504 plan, my oldest one, especially in and out of hospital. And that's so tough because you don't want them to get to the point where they feel that it's okay to make an excuse. But on the other hand, you want to make sure that they're appropriately treated and still able to keep up with their school studies. So it's a really hard balance for so many people. Let's jump right into some of the treatment questions that we have here. I have a lot of treatment questions. So why is it important for adolescents, children who have migraine, to have access to non-pharmaceutical options? Obviously, we know there are a lot of medications. We're going to talk about that. But let's talk, for example, about medical devices. Why is it important that that parents of these children are aware of some of these options?
Well, it is important. There's a lot of families who don't like to take medication. So that's one thing. And now it's an exciting time for migraine because we do have options right now. The devices are not medications. There are a few of them that are cleared by the FDA. They show that they can give a good response. The other issue is, to take a medication, you have to leave the classroom, go to the nurse to get it. With the devices, you can do it in the classroom. So the child is not even leaving the class, missing school. The child is there, they put their devices, and they continue staying in the classroom. And they are effective. They have shown to be effective, sometimes more than just ibuprofen. There are patients who are chronic, so they have continuous or daily headache, and they cannot take medication every day. So that's an add-on for the days at least where they cannot take medications.
Right, absolutely. Let's talk about some of those devices real briefly. What is the difference between a device, for example, that may just be advertised on Facebook or other social media, on Amazon, versus a device that's actually FDA cleared for migraine? What does that mean? And what does it mean to have an adolescent indication as well?
Yeah, to be FDA cleared, they have to show that it's effective and that does not have too much side effect. If they're not cleared, it means they did not show anything scientific to prove these two options. Most of them, except one, is a prescription. So you do have to
Okay.
write a prescription like any other medication. The only one that does not need a prescription is the cephalate. Did I answer your question?
Yes, you did. Now, do all of those actually have an adolescent indication, or do some and some not?
Most of them do, but there are some that don't have yet an adolescent. Most of them are approved as acute to break the headache for adolescent 12 and older, and also cleared, I want to say, they cleared for preventive. Some of them are used now as preventive treatment for migraine. So not just to break an acute pain, but it can prevent another headache from happening.
Right. That's helpful to know about that. I wish that there had been devices that were FDA cleared when my children were adolescents. It would have been great to have that option. It's great to see there's so many changes, but sometimes we look back and we think, wow, I wish, how would life have been different, then. So why don't we talk about some of the other non-pharmaceuticals again before we get into medical devices, into medications. Let's talk about lifestyle changes. Okay, when you have an adolescent, obviously not the greatest time in their life to try to enforce normal sleep habits, good eating habits, etc. How important are those lifestyle changes or adjustments, and what are the key ones?
Very important. Dr. Slater, do you want to talk about that?
So we kind of emphasize, and I think the way we do it in our clinic is that we kind of say that following the medication recommendations, the healthy lifestyle recommendations, and any recommendations about counseling or therapy are equally important. And whether they come to the new clinic or the follow-up clinic, they'll hear the same message. So we focus on hydration, eating habits, sleep, and exercise. And so we kind of go over with them. The neurologist goes over with them, first of all, about, okay, here's why we think it's important that you drink 8 to 10 cups a day, or, get enough sleep. Don't change your sleep schedule too much. Don't skip meals, exercise regularly. And then kind of when I go in or when I meet with families and patients, it's kind of talking about, okay, I do understand we're not trying to ruin your life, because usually sometimes they're really worked up about cutting out caffeine, things like that, about, hey, we're just trying to help you feel better. And if you really make this commitment, we really think you'll make, you'll find some big changes in how you're feeling. And so we'll go over, okay, what are the barriers to do this? How can your family be supportive? Do we need to put some reminders on your phone? Like nowadays they have some really cool apps that can, for hydration and things that kids might be kind of, interested in, and kind of help them make those lifestyle changes.
Right, absolutely. That's helpful. Challenging to do, but so important, right? To make sure that they have that kind of along the same kind of lines. Maybe Dr. Slater, for you as well. Let's talk a little bit about stress management. We know that, especially during adolescence, stress really can increase, and we know that can be a trigger for migraine as well. What are some of the best ways for adolescents to be able to manage stress?
Yeah, I think what generally we try to start with is to try to figure out, what might be stressing them out. Like, is it, taking lots of challenging courses? Are there some social issues at school going on? Are there family stressors? So we'll try to kind of figure out what's going on with that. And then, some of those are not super easy to do. Sometimes when at school, it can be, hey, let's go back to, are there some accommodations that would help you if you're feeling like I'm really stressed because, when I have these headaches, I'm not able to do my best and I'm a really good student, and how do I do that? So sometimes that, and I see them follow up when they come to my office, say, oh, that's so helpful that, I'm doing that. And sometimes it does take, some outpatient counseling or therapy. And so in those ways, that's when we might make a referral for cognitive behavioral therapy for pain, to not just in a brief assessment or intervention, but hey, let's meet for 5 or 6 weeks, 7 or 8 weeks, to talk about, first of all, what's stressing you out, what's making you feel sad, angry. All right, how can we help you manage those emotions better so that it will help with your headaches?
Right, absolutely. That's good to know. Do you see a lot of success specifically with cognitive behavioral therapy? Is that something would you say that's one of the better ways to go, or just kind of one of many tools?
No, it definitely is a primary recommended treatment for children, adolescents, and adults with migraine headaches.
Right.
I know, like I think the success rate in terms of both sometimes in reducing pain frequency, but also increasing functioning and coping. With the kids that I've seen, I've had upwards of at least 80% were able to decrease their, functional disability by a significant amount. More than half of people were able to reduce, in studies that we've done, reduce their headache days. And so we feel like that's one of our most effective treatments. And so I do think at our hospital, we have psychologists everywhere. So they're usually okay with, over the, almost 20 years that I've worked here. First, I think kids will be like, oh, do you not believe that I have a headache? Is that why you're sending me to see the psychologist? But they see us like at random times. Like sometimes I'll see people in my office and I'll be like, yes, I know you saw me in neurology. I'm not following you around. I'm also the person that you see to kind of do this intervention to help with headaches.
Right. And there was a study that was published a few years ago comparing amitriptyline by itself and amitriptyline with cognitive behavioral therapy. Both groups did well, but the group that did the cognitive behavioral therapy for migraine specifically did much, much better. Even after they stopped their amitriptyline, they were functioning much, much better too. So we try to combine all these treatments together as much as we can.
Right. Yeah, that's good to know. I know that, in my online community, we talk about the migraine toolbox. It's not just medications. It's not like I would say a one pill and done thing. Yeah. You need to have, all of these options available to you to see what combination is going to work and sometimes shift it, right? If something stops working, you may need to be constantly figuring out some alternatives. Let's talk about supplements. So what supplements would you recommend for people who are under 18, specifically in the adolescent age range, for preventive treatment for migraine?
So I'm going to talk about our center. So there are 4 vitamins we look into. It's the vitamin D because it has shown to be low in any type of pain, not just migraine. Right. The other one is the coenzyme Q10. There are a few studies, small study, that shows that it can be low and replacing the CoQ10 can help with a headache. I think Dr. Slater was one of those studies on CoQ10. The riboflavin, the vitamin B2, and now there have been a lot of studies on folic acid that can be low too in migraine. We don't look at we don't look at magnesium and things like that. We do not give our patient right away those vitamins. We do check on the levels. If the levels are low, then we supplement, because there's no reason, if we're going to push 4 medications on them, plus the abortive, plus the medication they have to take to prevent their headache, the adolescents are not going to fall for it. They're not going to take it. They're not going to be compliant. So we do the blood test and we supplement only if it's low.
Right. That's interesting to know. Talking about compliance, probably a term that most people with migraine really don't like. I definitely don't like it because I feel like, you're telling me what to do as opposed to treating me as, as a human being. And obviously we know that adolescence is probably the least compliant time in your life, right? So it can be very challenging. Do you generally find that adolescents are more likely to use a treatment that's just an occasional treatment, or a treatment that they're going to use every single day? So maybe just explain a little bit more. If we're going to get onto medications in a moment. So we know some of those medications, some of the injectables, especially just once a month, once every 3 months, some of the oral tablets are every single day. Does this tend to be a leaning in adolescents one way or the other, or is it just totally individual?
It is very hard to take medicine every day for any person. And that's why we want the teenager to be on our side. And that's why we want to involve them in the final decision. Like I said, if they don't want to take it, they're going to say, I don't want that medicine. And they're not going to be compliant at all. So that's one thing that we make sure, hey, what do you want? Do you think you want to be on a daily medicine? And if they say no, we'll say, that's okay. We will watch you for 6 weeks, bring you back. But if the headache are still intractable, we may need to be a little bit more aggressive. So they take it this way. They feel they are in control in their treatment. It's not us throwing things. And I think Dr. Slater may know more about compliance, because I think I even have a clinic for that.
We do have a pretty large adherence clinic. And I do think it can be difficult, especially the more kind of pieces of treatment there are. So if they've committed to do one of the preventative medications, we try to talk about what barriers there might be. Are there other medications that you take at this time of day? Is there something you always remember to do that we can pair this with? Nowadays, like I said, everybody's attached to their cell phone. Are there some reminders that we can put on your phone, so that even when you're at your friend's house, when you come back, you can do that? So we do try to have that behavioral piece on there to kind of empower them also. Like, this is the thing that you're going to have to do, especially for adolescents and teenagers, because oftentimes they're not actually at home. So, okay, how can we make it so that it's not always mom or dad or someone else that's kind of, because then if they kind of feel like their parent is nagging a little bit, how can we make it so that you remember to do this, so that you can take it in a fashion that we can know whether it helps with your headaches or not.
Right. I love that because, a lot of, from what I see, a lot of adolescents will drop off seeing a doctor and managing a migraine once they leave home. And so it's really important to establish that while they're still at home, that their role in it, how important it is and what they can do to make a difference, right? Let's talk about some medications. We know that obviously most medications are not tested on people under 18, which is a huge problem. So as much as adults often feel like guinea pigs with medications, how much more so with children? And yet we also need to manage the balance of them still having some kind of quality of life. So if nothing else is working, what are the types of the classes of medications that you most recommend? And are any of them actually tested on adolescents?
Well, when we see the patients, we describe the treatment as 3-part, like Dr. Slater mentioning. The first part is how we're going to break an acute attack. When you have a headache, how we're going to break it. We want to break it fast. We want it to totally go away. We don't want the headache to come back, and we don't want side effects. The second part, if the headache are frequent or if they're disabling, then we have to be a little bit more aggressive. And we do have to offer some preventive medicine. This is the part where the patients who are younger than 18 don't have all these broad treatment that adults can have. And it takes 10 to 20 years to get it approved for kids after they're approved. So it's really a long 2 decades for the kids to really get those great medications. And the last part will be the healthy habit and cognitive behavioral therapy. For the acute treatment, since migraine has some part of inflammation, it's an inflammatory process, so we do use NSAIDs. So that's the first line we use for kids: ibuprofen, Aleve, naproxen, and things like that. If this does not work, or we feel like something more aggressive needs to be done as acute, we do have the triptan now approved. Not all of them. These are more vasoconstrictors that are approved. One of them is down to 6 years old. And again, it took 30 years to get it to get there after it was approved for adults. So these are combination we can use. We can use the NSAID, the anti-inflammatory by themselves, or added triptan for a really severe headaches. The other, we call them the CGRP medication. This is a hormone that triggers that inflammation. They are not approved for younger kids. So it is really hard to get it approved. If it is medically necessary, we may be able to get it approved, but it's very expensive on the parents. And they will not help them because it's not approved. So they don't get the help from the pharmaceutical companies to get it approved.
Yeah, that's a big challenge, just getting the insurance to cover it. And then, monitoring it. A lot of parents find it really hard to stomach the thought of giving their children prescription medications for what they may coin just a headache, right? Can you talk a little bit about central sensitization and chronification, big long words, and how that kind of plays into the best way to manage a disease like migraine?
Yeah, so like I mentioned, it's an inflammatory, and the nerve too are involved. To make it simple is, if we don't catch it, that inflammatory process continues, and it's going to build up, and you end up not only having the headaches, it builds up where you are sensitive all over. So even your skin, if you touch my skin, the hair, they will tell you my hair hurts, which, well, we will say, oh no, there's no way, but your hair, we call it allodynia. When you start going through that process, you're at high risk for what we call chronification. it means the headache is going to turn to a chronic headache. It will be very difficult to control, and it's going to take months to control. And that's why at this point, what we try to do, and we're talking to the pediatrician, to providers in the community, because this is where the patients go. Hey, we really need to catch those headaches when they're not frequent, when they just started, and we need you to know how to treat it. We use a higher dose of anti-inflammatories, and they're worried, the pediatrician, to use that. They were not comfortable with the triptan because they were not approved. So a lot of kids will go to the pediatrician but don't get the right treatment until their headache is chronic before they are referred. And we want to try to catch it before that phase as soon as possible.
Right. Interesting. This may be kind of a tricky topic to talk about, but obviously we know that anything can have side effects, right? I mean, anything natural, anything fabricated can have side effects. But obviously, as much as we do as adults need to watch out for side effects when we start something new, and decide whether or not that's tolerable, balancing like the risk versus the benefit. What are some of the important side effects of some of the most frequently prescribed medications that parents need to look out for? Obviously, I'm not asking you for side effects necessarily for specific medications, right? But, what are some of the things we just need to be aware of?
Yeah, so even over-the-counter medications can cause side effects. So we use the anti-inflammatory ibuprofen. It can give you some stomach pain. So we discuss, we have to limit, you just take it, you can repeat it one time. We do limit the treatment for more than 3 times a week, because if we use those treatments more frequently, the body become immune. It's not going to work. And not only it's going to work, one of the side effects is headache. So you can get yourself into what we call analgesic overuse headache. So it is a side effect, and we don't want you to end up with those extra headaches. As far as preventive medicine, any medication has side effects. The main thing is to let them know, yes, they do. They're less than 3%. They're not that frequent, but you need to know, because you may need that. You may be the 1-3%. And we discuss in details what are the possible side effects. And if you have them on this medicine, you call us. And there are other things we can switch you. And we let the parents and the kid decide. These are the medicine we can start you. Which one you feel like it's appropriate for you.
Right. Right.
And they ask, no, you pick for us. I say, I can't. I can tell you they're both effective. The decision is on you, which one you can take. Some of them are once a day, some it's twice a day. If for adherence, you want the once a day. If you don't sleep at night, this medicine may be better, and things like that.
Right. Yes. And I always like to talk to people about the side effects of not taking medication or not using devices, not doing this, right? It's so important. Migraine will easily quantify. I'm a great case example of that. There was nothing when I was a child. There was nothing when I was an adolescent, and even as a young adult. And so, I often tell my kids, please make sure you're taking care of your migraine, because you're going to end up like me. Of course, no adolescent or young adult really kind of listens to that, but it's so true. There are a lot of people in my generation that just the chronification is just so severe partly because we didn't have these options. So
Correct.
It is exciting that there are options now. And at least for me, looking back, it's really amazing. If there was anything worse than having severe and frequent migraine attacks, I'd say it's watching your child go through that.
Having it, yes. And this is how family gets affected. The parents are frustrated. I can't do anything. Yeah.
Right, absolutely. So let's talk about some of the more extreme types of migraine, in terms of migraine attacks where the pain is excruciating, you can't manage it. At what point should a parent take their adolescent to the emergency room or ask for them to be admitted to hospital? And I know that that's going to vary depending on where in the country you are, but ideally, like in your situation, what is your recommendation?
So what we teach our patients is, first, you want to make sure you treat your headache as soon as it starts. That's magic. If you don't do that, for sure, it's going to be harder. If you go, if it starts at school, you go home to treat it. That's hours before you get home. And when they call with a really bad headache, we do ask them, did you treat it? Did you repeat it the way we told you? If they did the right thing and the headache is continuing, so you will be in the category of what we call status migrainosis. That's a severe headache that's not breaking with anything, and it's very disabling. If they get to that point, then they may need IV treatment. There are infusion center. We do have an infusion center, so the patient don't have to go to the ER and wait. It's loud, it's bright, and they make you wait forever. So we prefer sending them. They prefer going to the infusion center. If not, we say you do have to go to the ER to have it broken. If not, then you may end up for days before the headache can go away if it does not stay. Now, let's say they go to the infusion center. About 75% will respond. They will break their headache, but you still have some patients who do not respond. Their headache is still there. The goal usually for us to get them to their baseline. If their headache were not continuous, they have to go back to zero from the infusion. If they're not back to zero, so it means no pain, then we do offer an admission to the hospital to get a medication called DHE every 8 hours until we break it.
Absolutely. Yeah, it sounds good. I remember that I was living in Houston at the time, actually, when my kids were very severe with migraine. And there were some amazing doctors there. And they would, sometimes it would just go to the ER, but other times they say, this is going to be a direct admit. Just don't even go to the ER, just come in, once they knew us and knew what was going on. And that's, that was just an incredible relief for my family. But it's terrible when it gets to that point. And so I definitely hear what you say, treat early rather than wait. It's
correct. Very important. Yes.
Yeah, absolutely. Now, one of the challenges of that, obviously, is if someone is relying on a medication, for example, to stop a migraine attack, and they only have 7 pills per month, but they're having more attacks than that, then, adults, we tend to ration, should I take it now? Should I not take it? Should I wait till the migraine gets worse? How do you talk to parents and adolescents about making that decision and convincing them that it really is important to take it immediately, even though in their mind it may be, I don't want to waste one of those pills that I have, right?
Well, the way we say first, they cannot treat more than 3 headaches a week. So we're limited as far as medication. Like I said, they can use the device. So now we're lucky we have the device. We do tell them to stratify it. If it's a small headache, treat it right away with your anti-inflammatory medication. But as soon as you know it's a bad one, you can add the backup medicine, and usually it's a triptan. So we do try to explain to them, you can limit it to the bad ones, but you have to take them as soon as you know it's bad, and you can repeat it. We usually try to prescribe the ones that where they can get 12. The triptan, anyway, they should not be using it more than 6 to 8 times a month. So we try to get them the one where they can get the most. But again, it's not in our hand. It's insurance covered. Sometimes they don't get the 8 treatment per month that they can have. But we save them for the bad one, but they do have to take it as soon as they know it's bad.
Right.
And they have the other option, and now with the devices, they can use that in addition to the triptan, or the days where they cannot take those medications.
Right, absolutely. And do you find that many adolescents will take, besides the medications, and the school nurse getting involved with the medications, do you find that a lot of adolescents are willing to use, these devices at school, take them around with them so that they have them?
Most of them, yes. And actually, we had patients coming asking for the device, and I would say, you don't need it. And they say, well, I want to use my phone in the classroom.
Oh my goodness.
But they do like it. But once in a while, a patient, I just had one last week, she said, I don't want the device. I said, why? Just for me to understand when I'm explaining it to another patient. She said, I don't want to look different. I don't want to pull it up and put it on to use it. But this is very rare occurrence. Most of them are excited. They want to see how it works. The barrier, it's usually more the cost than using the device.
Right, absolutely. We definitely need devices to be covered by insurance, that's for sure. I know, some of the companies are doing great at that, and we definitely need to be fighting for it as well. I was thinking, one of my young adult sons told me recently, I don't want people to know I have migraine. I don't want to do a video. I don't want to don't want to use a device. So it's kind of like you were saying, that stigma, they don't want to be different. And then when you're talking about the adolescent who's like, I want the device because that way I can use my phone, kind of highlights the challenges, right, of adolescents with migraine. Trying to manage that is definitely not easy. Dr. Slater, maybe I can ask you about, how you talk to adolescents and parents about the different ways that a medication specifically can be administered. So, for example, injections, right? Or nasal sprays, how do you talk to those patients about why it's important for them to use that? For example, if they're vomiting frequently during attacks, is there a lot of resistance to the injections and the nasal sprays, or generally not?
I feel like sometimes there is some hesitance. Like sometimes with the nasal sprays, we've had patients to come in. Usually they don't like the way it sort of tastes or whatever.
Right.
They don't really like that. Or the injectables, if people are scared of needles, then that's usually, a time that they might say that they don't want to do those sort of treatments. And so, it's all like there's so many different sort of treatment options. And so we offer all those to them. So there are different sorts of triptans they can do that are not that way if they want a pill. If it's a treatment, we oftentimes, probably the most common kind of barrier is that kids and teenagers don't know how to swallow pills, or they're afraid of swallowing pills. And so that is, super quick intervention, or at least that we'll talk to them about, hey, we want you to practice with candy. You're not scared of doing that. Like you can always you can swallow a cupcake sprinkle, because they're usually like, then they're like, right. Cupcake sprinkle. Yeah, I can totally do that. And so that's usually my inroad to say, hey, why don't you try it at home? Now your parents are going to have to buy you candy. You can say, Dr. Slater said they have to buy you some M&Ms.
They got to practice.
Yeah. And so sometimes we do have extreme cases where, they're like, no, I can't do it. We do have a team of psychologists here in behavioral medicine who can work with kids specifically on pill swallowing. So sometimes if they're crying and it seems, and the parents like, no, we've already tried all of that, then sometimes I'll make a referral to one of our psychologists who do the pill swallowing intervention.
Right. Absolutely. That makes sense. I was thinking the first time I ever injected myself, I was an hour with the nurse in my doctor's office, them convincing me to take this needle and put it into my leg. And it wasn't sub-Q as I am, so it was bigger than these tiny little needles. But I think really what gets me over it personally is just knowing that I have the opportunity for this migraine attack to stop really quickly and really effectively, and it's way better than ending up in the emergency room and having an IV put in and the pain of the needles. But still, is that kind of psychological jump to, can I actually give myself an injection, or is a parent willing to give them an injection, or am I willing to put up with this horrible taste of medication I'm putting up my nose, or am I willing to swallow a pill, right? The alternative, if that's, going to the hospital and having needles stuck in you and loud noise and stuff, then, it's kind of a no-brainer, but our minds don't work that way, obviously. We tend to panic about things very easily. Let's talk about doctors a little bit. We know that in the US, there are under 1,000 certified headache specialists, if we count both the UCNS certified and the AQH certified. My organization actually has a website that tracks every single certified headache specialist in the US. Not enough people for the 42 million people in America who have migraine, or for the number of children who have migraine. My guess is going to be that it's even harder to find a pediatric neurologist who is experienced and trained in treating migraine than an adult. Is that right? And what do we do about that?
Correct. Well, it is better now than when I started, because I know I was the first headache fellow for pediatrics. I was the guinea pig to start a program to train people. And this is where it is important to train the pediatric neurologist to take care of headache. They do, but they don't know the little details. This is why it is very important to bring those educational staff to the community, because we really don't have enough specialists. And even at Cincinnati Children's, the wait is long, and we have the shortest wait compared to any other headache center. The other headache center are 6 months to a year. So just until we start having more pediatric headache specialists, we do need to educate other physicians how to treat it the right way.
Right. Yeah. And I can imagine that part of that is for those doctors, those neurologists, recognizing the symptoms of migraine, because they're often appear different during childhood, right? Could you maybe just address that a little bit? How does adolescent childhood migraine present that's different from adults often?
Well, at a very young age, they may not complain of a headache. So there are other symptoms. They'll complain of vertigo, and suddenly the kid is scared and they will cry. So these are little symptoms that you don't see in adults, you don't see in adolescents. But if they repeat themselves, they're similar all the time, you have to start thinking about migraine if there's a family history specifically. There are what we call abdominal migraine. And again, it's more frequent in younger kids. They just have episodes. They throw up, and then nothing for a month. And then they do the same thing episodically. The primary care physician need to understand, they need to rule out other stuff for sure, but they need to understand that this can be a migraine. When the kids grow a little bit, they're more vocal, they will start complaining of a headache. So at least you will add that symptoms that's a little bit helpful. For migraine, if you look at the criteria even, it's not specific to children. They say a headache needs to last at least 4 hours. For kids, they can have a headache that's lasting an hour. And it is a migraine, not another type of headaches. So there are different headaches that present totally different depending on the age of the patient.
Right. Yeah, that's interesting. How can parents differentiate between the adolescent who says my stomach hurts, I can't go to school, and the adolescent who's actually having a migraine? If that makes sense, we know that that's a very common complaint that adolescents and children use to get out of doing something that they don't want to do, and yet unfortunately, if it's also a symptom of migraine. How can you differentiate between the two easily, or can you?
Well, the way we decided at Cincinnati Children's that we're going to believe the child when they complain. So we want to show them that we believe you. We do explain you still have to go to school if you have stomach pain and headache pain. So they know even if you're complaining, if you cannot to school, you're that disabled, you need to be in the ER, not in bed at home. So that's the first thing we explain. Are there times they may have a stomach pain, and just because they don't know go to school, Dr. Slater will know more than me. But again, we say they told you that, then it means they have it.
Right.
And we treat it this way.
Right. Interesting. Dr. Slater, do you have anything to add to that?
Yeah, no, I totally agree with Dr. Kabbouche. Definitely, it's not a matter of whether they have pain or not. Like I said, if you tell me your stomach hurts, it hurts. Let's talk about what we can do to help you feel better. If your head hurts, what we can do to help you feel better. But like I said, we try to emphasize functioning. Like we want you to treat it. What has your medical team said they want you to do to kind of treat this pain? All right. And now let's see what we can do to get you to school. Like they're going to let you have breaks. They're going to put off you taking this test until your headache resolves. We want you to go. And so I think in that way, it isn't like whether these people believe me or not. It's more, try to introduce it. This will help you feel better. Like we always say, there's studies that have shown that sometimes a return to functioning happens actually before your pain improves. So if you have a chronic pain condition, waiting until the pain is at zero, you're going to miss out on so many actually really fun things, really things we want you to be involved in. But if you actually go, that might actually help you feel better. You'll see your friends, you'll be distracted versus just laying in bed in the dark, just thinking about how awful you feel.
Right.
One thing we sometimes do, like younger kids, the mom will say, how do I know? What should I do? If they just come, yeah, my head is hurting, and then they disappear and go play. I said, the one thing we can start with, you don't have to give them the ibuprofen. They'll come, I have a headache. You can give them, we recommend hydration fluids, sports drinks. So you can start by doing this. You're not using the medication every time they come to you. Start with that. The child is going to feel you believed them. And then they see you offering something to help. And actually, we do use it for migraine too. So they can start with this first. But then if the headache is getting worse or the child continues to complain, then you have to go and give them the treatment.
Yeah, I love that. I think, I know that one of the most devastating aspects of stigma that as adults we face is that people don't believe us, right?
Yeah.
And all we want to say is, please believe me, please believe me. I have this and it's devastating my life. And, so also true, obviously, in childhood and adolescence. And I'm going to presume that if people are not believing you in adolescence, then that kind of sets the stage for you not wanting to even tell people, as you get older, which is taking you down a trail that is not a good trail to go down. So I like the fact that your default is that you believe them. And I think that's really good. We're going to be closing soon. I've kind of got through all of the questions that we have, other than, what would you say to parents are the most important things for them to know and do at this time? Let's say you have parents who have migraine, or one of them has migraine and their children are coming into adolescence. What is the most important things for parents to know and be aware of relating to this subject?
Don't be afraid of it. It is treatable if controlled from the beginning, and they need to seek help as soon as they notice the symptoms, because the outcome would be better.
Great. Thank you. Dr. Slater?
Oh, sure. I mean, I think I agree with that, and just even considering, addressing even psychiatric comorbidities can be an important, part of treatment as well. So that if, kids or teenagers are presenting with anxiety or depression or ADHD, that it also will be important, not just for their overall functioning and quality of life, but for their headaches, to address those issues as well.
Right. Yeah, that's good to know. Any final thoughts before we close?
Well, I don't want parents to be worried about cognitive behavioral therapy or the kids, because they think, like Dr. Slater said, oh, they're sending me, they don't believe me, they think it's in my head. And it's important to explain to them, no, we're teaching you skills to get over what's going on. And this is when they need to understand that's different than treating you for other stuff. It's skills that you can use all your life. And this is a new concept. People don't understand it yet.
Yeah. And I do think that, sometimes families, probably more recently in the past 4 or 5 years, that there's so many apps. And so I think there are lots of studies ongoing now trying to evaluate, different modes of treatment. And so sometimes when families are, oh yeah, I'm not sure, or I live kind of far, we'll give them a handout that has maybe some relaxation apps or some CBT for pain apps, and say, hey, why don't you just look it out, explore it, see what you think. And then, like I said, the new thing that we're doing is, ever since the COVID pandemic, that lots of counselors and psychologists are able to do therapy sessions through the computer or on the phone. And so we can do telehealth sessions. So I think that's actually opened up our treatment for a wider range of patients, because it, like you talked about before, in terms of pediatric headache specialists, there aren't enough also pediatric pain psychologists. And so that's been helpful as well.
Right. That's super helpful. I really appreciate it. I definitely really appreciate both of you being here today. For everyone who's watching the video, thank you so much for joining us on Migraine Meanderings. I hope that you have found this helpful. If you have any comments or questions that we have not answered in this event, please let us know in the comments. Migraine can be such a challenging disease to live with, and there are so many children's lives impacted early on. And so we encourage you to proactively partner with your child's doctors, explore different options, and create an action plan to help them manage the disease in their life, both now and as they grow up into young adulthood. Thank you so much for joining us today, and have a great day. Bye-bye.
Thank you.